So here's what I want to do. At the end of my talk, I want you to feel comfortable answering two questions. The first question is this dementia? And your response to that question from your patient and their family would be no, maybe, not yet, or yes. I want you to be able to sort of have in your mind why you would use any of those four responses. And then the next question I want you to be comfortable answering is this Alzheimer's disease? And what I want you to feel comfortable formulating a response to that would be no, possibly, partly, or probably. So 4 responses to those 2 questions. I want you to try to get a feeling for why you would answer those questions in different ways. So Sarah and Kuzmina already covered this, but I just want to put in my own 2 cents. Why diagnose dementia, and why diagnose a specific cause of dementia? Especially that last one is what I'm going to talk about. Well, people want to know different diseases have different prognoses and have different implications for the family in terms of genetic risk. There's always secondary prevention to be done in terms of preventing delirium or excessive disability. There's advanced directives to be sorted through. There's community resources to be discussed. There's home safety to be reviewed and interventions planned. There's a driving evaluation discussion that has to be had. There's referral to community agencies. There's treatment. Heidi will talk about treatment later in the day. And then there's clinical trial referral, which is dependent on the specific diagnosis. So dementia doesn't happen overnight. At least neurodegenerative progressive dementias don't happen overnight. People who are aging have the normal expected changes in cognition with age. At some point, if they are developing a pathologic process, they're going to start to show symptoms. And that phase of progression to a diagnosis of dementia is called mild cognitive impairment. And then, of course, once they develop dementia, the course of these diseases tend to progress more rapidly over time because there's less and less neuronal structure to support cognition. So once the bridge starts to sag, it starts to cave in faster and faster. So if you think about different cognitive domains and this spectrum of pathology, thinking about recall and learning, executive function, reasoning, navigation, speech, and behavior, normal aging, recall and learning is less efficient, but it's intact. It takes more repetition and focus. As we get older, we can't multitask and learn something. We develop ADD. We have to focus on something. We have to think about something if we're going to remember it. But encoding of new information, although less efficient, and retrieval of previously learned information, although less efficient, is still functionally intact. Executive function, wisdom, reasoning, those are still intact until there's pathology. Navigation abilities should be okay, functionally intact. There's noun finding problems, name finding problems, mild word finding difficulties, but no frank aphasia. And as far as personality and behavior are concerned, you just get to be more and more like yourself the older you get. Now, as you develop some pathologic process, you transition into the phase mild cognitive impairment, in which, in the classic form as initially described in 1999, it was amnestic MCI, a prodrome to Alzheimer's disease. Well, we know now that that's a little oversimplistic, but in the classic form of prodrome to Alzheimer's disease, registration, recall, and learning are impaired. But these other cognitive domains, at least initially, are intact. Executive function, IADL function, reasoning, navigation, speech, and behavior are all intact. We know now, though, that people can actually, that this is a progressive process, number one. And number two, people can have more than one domain affected. I'll talk about this later. But it's a moving target, it's a transition. So you can't really define MCI in one specific way because it's a graded process to dementia. Now, when do you call dementia? When do you slam your gavel down and give a person a life sentence? When do you call, what is the tripwire for that diagnosis? Well, okay, recall and learning, impaired, but the tripwire is IADL dependency, is functional dependency. When you're no longer able to get through a day safely without somebody else's help and actually accomplish something. That's executive function, and that's the tripwire for dementia. That's the functionally significant impairment. It's not memory impairment. You can do quite well with memory impairment up to a point. You can't function without some reasoning, thinking, and decision-making ability fully intact. And that's not age dependent. Older adults without any pathologic process are brilliant. Navigation starts to be affected in MCI and becomes impaired with dementia. Speech starts to become impaired with MCI, gradually worse word-finding difficulties and disfluency, and then it's impaired with dementia. And by the time MCI is progressed and dementia develops, a person's behavior and personality starts to become more dramatically affected. So mild cognitive impairment, as initially defined, consists of a stage of subjective memory complaint, but normal ADLs, normal IADLs and ADLs, and normal general cognition. We know now that that's actually the amnestic subtype, abnormal memory for age, and the lowest 10 percentile for age of ability to register and recall new information. Seems to be a pre-dementia phase, often progressive, and it progresses at the rate of about 12 to 15% per year versus 1 to 2% per year with normal memory. So if a person does poorly on memory testing but is still functionally significant, and all of the things look to indicate this may be a progressive process, not related to other pathologies, then you might say that this person has a risk after 4 years of 48 to 60% risk of being functionally demented. That is, this amnestic MCI is likely Alzheimer's disease, and at the end of 4 years, 12 times 4, 48%, 12 times 15, 60%, somewhere about 50% risk of needing help day to day after about 4 years. Now we know also that there are non-amnestic forms of MCI which are likely predictive of developing vascular dementia, Lewy body disease, and etc. Now DSM-5 defines mild neurocognitive disorders, so there's the advantage of years of research now because these criteria just came out last year. So this is evidence of a modest decline in one or more cognitive domains. So now we know that MCI is just not amnestic, that there can be a problem with complex attention, executive function, learning and memory, language, perceptual motor, and social cognition that is measurable decline from a previous baseline, but not functionally significant to the extent that they need help day to day. The problems do not interfere with independent function. But, and the cognitive problems do not occur exclusively during the course of delirium or due to some type of mental illness. The underlying cause should be identified if possible, and they should be reassessed every few months because of that risk of progression. Now, we're fond of the clinical dementia rating scale. This is generally a research tool, but we find it helpful in clinical situations to define severity and define the functional stage at which point we might say a person has dementia. So we use it in a completely invalid way. You can, but we find that a functional assessment like this has to be used because some of the cognitive tools are overly sensitive and underly specific. Underly specific, not specific enough. So that to avoid false positives, we delay the diagnosis of dementia until they score on a functional tool like the Cognitive Dementia Rating Scale. This is the way it's done in clinical trials, that a person is not defined as having dementia until they score a 1 on the Clinical Dementia Rating Scale. So I don't know if you can see this, but there are 6 domains of function: memory, orientation, judgment and problem solving, community affairs, home and hobbies, and personal care. Now there's a structured interview that goes along with this, but frankly, it works very well as just a clinical tool. And if after you've done your cognitive assessment and your functional assessment, in other words, you've gotten a history and you've done your exam, you can fill this out in 6 seconds by circling the descriptor that best describes where your patient is at that point. So for questionable dementia, 0.5, that second column to the right, as far as memory is concerned, consistent slight forgetfulness, partial recollection, benign forgetfulness, orientation, fully oriented except for some time disorientation sometimes, slight impairment with judgment and problem solving, but generally independent, slight impairment in community affairs, life at home and hobbies and intellectual interests slightly impaired, but still engaged in these activities. This defines MCI, 0.5 on this scale, or you can sum the boxes up. This would be a 2.5, and scores around 6 or above would be dementia. And they're fully capable of self-care. I find tools like this to be very useful in defining mild cognitive impairment and withholding a diagnosis of dementia, regardless of the cognitive test. So here's a Mocha. A person is getting a 24 out of 30 on this Mocha. I think Josh Bridges in Bangor, in the audience there, did this. It wasn't his Mocha, but he admitted. Josh, you get a 30 on this. I know that. But this is a 24 out of 30 for this patient. You can see they're a little funky on their trails, a little funky on their cube. Their clock is good. Their verbal fluency of 14 is pretty good. And they got 1 out of 5 on their memory, and they were fully oriented. So this 24 is classic, in that sort of classic MCI dementia threshold. But on their clinical dementia rating scale, they're a solid 0 or 0.5. They're a little forgetful, slight impairment in community activities. They're not as engaged in the community as they used to be. But otherwise, they're perfectly fine. They still drive. They still manage their checkbook. They manage their medications, but you probably do want, because of the forgetfulness, you want a backup system for medications, and you want a backup system for finances and so forth. There has to be a watchful eye for safety, because this is a moving target. This is progression. This likely will progress. And because memory is affected before executive function, predictably, this is likely Alzheimer's disease in the pre-dementia phase. You don't necessarily say that. Depends on how much information the family wants. All right, but at some point this will progress. So when do you bang the gavel? This is dementia. The National Institute on Aging Task Force defines dementia as a cognitive problem that interferes with function. It's a decline from a previous level of function. It's not due to delirium or mental illness. The impairment is validated by testing, a Mocha score under 24. The impairment is not just memory, but is present in at least 2 domains: new learning and memory, executive function, visual, spatial, language, or behavior. There's no score here to determine when you say that this is a decline from a previous level of function that's significant enough to matter. This is a clinical judgment. Don't be tied to the score on the mental status test. Now the DSM5 criteria, which just came out last year, and by the way, the DSM5 Committee for Neurodegenerative Diseases thinks the term dementia is pejorative, dementation, and are trying to get us to use major neurocognitive disorder. Well, that is a mouthful. Anyway, the criteria are very similar. Evidence of decline in one or more cognitive domains from subjective report or testing, meaning functional status or cognitive test, quantitative cognitive testing. Cognitive deficits are severe enough to interfere with independence in everyday activities. That's the functional status. That's the defining criterion. Cognitive deficits do not occur during the course of delirium. They're not due to a mental disorder. And the underlying cause should be identified if possible. So again, functional criteria, not a cognitive test score, although that provides necessary evidence. So when does it start? Well, with Alzheimer's disease, we know it starts in the entorhinal cortex in the medial temporal lobe, and it spreads from there into parietal and frontal lobe, and that's when MCI starts to trend into functionally significant symptoms. That's when you start getting navigation problems from the parietal involvement. That's when you start getting frontal executive dysfunction from the frontal involvement. This disease spreads from the medial temporal cortex into parietal and frontal cortex, and at some point it involves the cingulate and more dense involvement in parietal, occipital, and frontal cortex, and now you have a global dementia. But at what point in this process do you say this is dementia? Now, not only do you have this sequence of events coming about over years, but you also have daily and weekly and monthly fluctuations. We all have diurnal variation in cognition. If you're demented, you have no cognitive reserve. Your cognitive reserve is exhausted, gone. So when you sundown, you become delirious. When you have MCI, you have razor-thin cognitive reserve. When you sundown, you become demented. Or when you have a UTI, you become delirious, or some minor physiologic aberration. But just diurnal circadian variability can make a person who's got MCI look demented. And so in clinical trials, they make us do the ADAS-Cog, they make us do our cognitive testing within an hour window, same time every day, because of this, because these people have no cognitive reserve. They're going to fluctuate. They're like a flickering light bulb that's on and off. When I sundown, I get ADD. I don't get delirious, I don't get demented, but I get ADD. So, because I have, you'll grant me, some cognitive reserve. So I can withstand some fatigue. But if you have no cognitive reserve, if you have MCI, you're going to look very different at different times. It's the report of day-to-day, week-to-week function that matters. Okay, so here's a person with scoring 18 out of 30 on a Mocha, and you can see now pretty significant executive problems, pretty significant visual spatial problems and executive problems with the clock. But they're still able to name these animals. They're still able to, took 2 trials to encode information, but they couldn't remember any of the 5 words that took 2 trials to encode. And they missed a couple on orientation. So they get an 18. Well, that's starting to become unambiguous. However, we still see people, even at this score, who are fully independent. Now, it's true they may not be functioning optimally, but do you want to say they're demented? It's a judgment call. Typically, this score would be indicative of functional impairment, but it's not always the case. Also depends on education and other things. This person happens to now have a CDR of 1. They're starting to show impairment in other domains and more severe memory problems, more severe problems with orientation. So they're scoring a CDR of 1. This is mild dementia. I feel comfortable diagnosing this person now. So now you start to get the services and the supervision in place. And hopefully you've been monitoring this at 3-month intervals or so forth, because you knew this person had MCI, you knew this day was coming. And you see that its memory is leading the way, and they have a normal neurologic exam, a normal history and so forth, and their MRI is consistent with Alzheimer's disease, and there you say Alzheimer's disease, and now you go with it. So what are the causes of this condition? Well, that person probably had Alzheimer's disease, but there's many, many different degenerative diseases that can cause dementia, both primary and secondary. And you have to, sort through this in a differential. And then there's the reversible causes, and we're going to go through some of these causes. Now, the reversible causes are numerous, and we all know the basic workup to look for these things. It used to be said that 20% of presentations of dementia were reversible, that they were hypothyroidism, they were medication related. When I was a fellow, there was a sleeping drug called Dalmane. I don't know if some of you remember that, but this is a sleeping medication that had a half-life of a week. And people would take it every night. So we used to walk all of our geriatric consults at the Portland, Oregon VA hospital were Dalmane related. They were falling and they couldn't wake up. So stop the Dalmane, stop the Dalmane, stop the Dalmane, and the fog lifts. So we don't use Dalmane much anymore, and we still have a fair number of medications that we have to look at carefully. Now it's anticholinergic drugs, especially antispasmodic incontinence medications. Still some people on amitriptyline, still a lot of people taking Benadryl. There's still a lot of drugs out there that need to be looked at. We have infections still to consider. In the late 1800s, syphilis was one of the most common causes of dementia. In the late 1900s, HIV infection was one of the more common causes of dementia in younger people. You had to consider infections. Now, in this area, you have to think about Lyme disease. So infections are still relevant to this workup. Normal pressure hydrocephalus, still a factor. You have to think about it when you see a triad of gait apraxia, incontinence, and later on developing cognitive problems. So we have to think about all these things. And some of these cases may only be partially reversible. There are new data, recent reports, that some medications may actually give rise to persistent cognitive problems. There are reports that benzodiazepines, antihistamines, I don't have that up here, but antihistamines and anticholinergic drugs may increase dementia risk, not just cause cognitive impairment, but may actually cause neurodegeneration. And the analyses suggest persistent effect, but it's very hard to adjust for this statistically and in a retrospective design. The brain is a plastic organ. It responds to medications. Some medications have neuroprotective effects. Some medications may indeed have neurodegenerative effects. Antidepressants may have a neuroprotective effect. But there's some concern that anticholinergic drugs and benzodiazepines may have persistent neurodegenerative effects. The dose and the duration of risk, we don't know yet. But these medications are often used to treat dementia-related symptoms, so it's hard to know. A lot of people are put on these drugs because they're developing symptoms related to dementia, but the drugs may, in fact, make cognition and function worse. And we don't yet know whether that may be persistent. I doubt it personally, but I think the cause and effect hasn't been established here. Labs and imaging, Cosmino went through this. I don't know, does anyone still get folate levels? I don't. Does anyone ever have folate? It's still in the practice guidelines, but imaging is probably advisable in everybody unless they are very old and their dementia is severe. MRI is better for a number of reasons, but anatomic CT is okay. PET, SPECT, LP, I'll talk about those in a little while. At the University of British Columbia, Harold Feldman's clinic comes up with these numbers for their assessments. About half the people have Alzheimer's disease, another quarter have Alzheimer's disease mixed with something else, usually Lewy body or vascular. There's a lot of Lewy body pathology in people with Alzheimer's disease. In one series, as high as 40%. Vascular dementia alone, about 8.7%. Frontal temporal, 5.4%. Lewy body disease, 2.5%. Unclassifiable, 1.8%. That's pretty good. That's pretty low. I'd say these are probably consistent with our clinic. So, when do you make the Alzheimer's diagnosis? Once you've established that a person has dementia, well, it's based on the history and the exam. So, and there are different levels of confidence in the diagnosis of Alzheimer's disease. Probable Alzheimer's disease, there is dementia that had an insidious onset, worsened over time. The worsening over time is key. And the amnestic presentation is much, much more likely because of where this disease generally starts. But there are some non-amnestic presentations, people who may have aphasia first or agnosia first, they don't recognize, they have perceptual abnormalities first. But that's generally rare. Those symptoms generally occur with frontal temporal lobe degenerations, but it can be Alzheimer's disease too. There are no other diseases, meaning cerebral vascular disease, Lewy body disease, traumatic brain injury, dementia, depression, and so forth, to account for the findings. And supportive evidence adds to increased level of certainty, not required for diagnosis, but adds to the level of certainty. That is, genetic testing, imaging, and CSF biomarkers. I'll have more to say about that. And if you're not sure, possible, you can say, or mixed types. You can still diagnose this, multiple causes, or possibly, not certain. DSM5, major neurocognitive disorder, is very similar, that dementia is present, or major neurocognitive disorder, insidious onset, gradual progression, decline in memory and learning, and at least one other domain. So it's not amnestic MCI, there's definitely something else. The disease has now spread to parietal or frontal cortex. There's no evidence of medical, neurologic, or psychiatric condition that would explain the findings. Or there is a genetic or biomarker confirmation before dementia develops. Okay, now get this. Now here's diagnostic criteria that now allow a diagnosis of Alzheimer's disease in somebody who does not yet have dementia. So this is kind of a scientific breakthrough, that we have now enough data of biomarkers to make this the diagnosis, to separate Alzheimer's disease from Alzheimer's disease dementia. Kind of a radical idea. So both these new criteria incorporate biomarkers to allow for diagnosis in preclinical, no symptoms, or MCI stages, meaning forgetfulness but not yet dementia. The NIA criteria acknowledge rare amnestic presentations where a person may have Alzheimer's disease but not be memory impaired, rare. And the NIA criteria no longer impose that old age criterion of between 40 to 90. Now 90 is an interesting age. People get diagnosed with, you can now diagnose Alzheimer's disease in people over 90. I'm not sure you should, because it's a different disease then. Most 90-year-olds have Alzheimer's pathology. Do they have Alzheimer's dementia? My aunt was 92. She got a diagnosis of Alzheimer's disease. I said she doesn't have Alzheimer's disease. She weighed 80 pounds. She had frailty. She had sarcopenia. If you lose muscle mass, you lose brain mass. If you don't have myotrophic factors, you don't have neurotrophic factors. If you weigh 80 pounds and you're wasting away from frailty syndrome, you don't have good cognitive function. She had Alzheimer's pathology, I'm sure, but she didn't have Alzheimer's disease. She was a little forgetful, but she could think fine. My little personal anecdote here, but the pathology I'll show you in 90-year-olds is different. Positive biomarkers do not rule out second or mixed etiologies. That's possible Alzheimer's disease. Even if you have positive biomarkers, you can still have cerebral vascular dementia or Lewy body dementia. And in fact, many people do. Are clinical criteria good enough? If you apply these diagnostic criteria, still 15 to 30% of patients may not have Alzheimer's disease as their primary cause of dementia. So let's look at this. I don't know if you can see this adequately, but there is a cascade of events that occurs in people with Alzheimer's disease where you get amyloid deposition for many years. Eventually, that triggers neurodegeneration. You get synaptic dysfunction, you get glial activation, tangle formation, neuronal death, and cognitive decline. You have some risk factors that determine the rate at which this happens: age, genetic factors, cerebral vascular disease, other types of brain diseases like depression and Lewy body disease. And then you have protective factors down below, brain and cognitive reserve factors, and environmental. I think by environmental factors they mean diet and exercise. And those slow the process down. Those enhance your cognitive reserve, and they let you withstand this process longer before you get demented. All right, but here's some biology that's measurable to define this process. So here's biology that's measurable, and there's structural MRI. And if you order an MRI, I encourage you to order coronal sections, because that way you can look at this plane. On the right is a coronal section from a person with Alzheimer's disease, and you see global atrophy and big space around the hippocampus. There's hippocampal atrophy. And the rate at which that happens defines, really kind of sort of defines, is sensitive to when a person is transitioning from MCI to dementia. So they have this global atrophy. So volumetric MRI is one biomarker. And here's how a coronal section might look on an MRI. And on the right, which is on the left of the screen, the right hippocampus is a little atrophied. And I don't think this is a great example, but you can see some temporal lobe atrophy and hippocampal atrophy. This person supposedly has Alzheimer's disease. Now you can do other things. You can do a PET scan which looks at neuronal activity, or you can use fancy labeling to actually look at amyloid deposition in the brain. And on the left of the screen, a person with Alzheimer's disease, if you look at their that sagittal view, you can see that the frontal lobes light up red and the parietal lobes light up red. That's where the amyloid is. That's where the Alzheimer's disease is. And that's where their symptoms are: visual spatial problems, executive problems. Also, their temporal lobes are probably involved too on the coronal section on the top. So you can actually label amyloid. This is another biomarker. Or you can do metabolic PET to see that these areas of the brain have less perfusion and less metabolic activity. So instead of seeing red and yellow in the frontal and parietal lobe, you would see purple and blue in those areas. And that's the PET signature of Alzheimer's disease. So we have various biomarkers. We have brain amyloid plaque deposition, which you can measure by PET labeling amyloid, or you can measure beta amyloid in the CSF. You can determine risk for A-beta deposition by ApoE genotyping. You can measure neurodegeneration because CSF tau, total tau, and hyperphosphorylated tau correlate with how much brain damage there is. You can look at metabolic or fluorodeoxyglucose PET to determine how much brain damage there is, how active the brain is, in other words. Or you can do volumetric to look at how much atrophy there is. So there are these quantitative techniques. Should we be doing these? Well, I don't want you to be doing these things, actually, but, except for maybe the volumetric MRI. But I want you to at least have a little concept of who you might consider referring for some of these tests. So I want you to know a little bit about them. So if you look at this graph, all the way on the left is amyloid deposition, which begins years before a person develops symptoms. You start to develop symptoms, which you see all the way over to the right. The purple line is memory, and the green line all the way to the right is function. Well, that's dementia, right? That's when dementia starts. So you can see that amyloid deposition predates dementia by years. So what have we been trying to do to stop Alzheimer's disease? We've been using anti-amyloid therapies. Well, if you already have the symptoms and you start getting rid of amyloid, you're too late because the neurodegenerative processes, tau-mediated neuronal injury and brain structure damage, once that process starts, reducing amyloid isn't going to do anything. So these studies have been negative. So now they're going back and they're doing anti-amyloid therapies before you get tau and before you get atrophy. All right, so you see that there's a lag period here. But we can use these markers diagnostically. Now, should we? Well, low A-beta 42 and high tau is the AD signature, is the Alzheimer's disease signature. So low A-beta peptide, it's reduced to 50% of control values. In MCI patients, it's 95% sensitive to prodromal AD. So if a person has MCI symptoms, amnestic MCI, and they have low A-beta 42 in their cerebral spinal fluid after a spinal tap, well, there's a good chance they actually have Alzheimer's disease and will progress to dementia at some point. In people with Alzheimer's disease, tau is high, 200% of control levels. It's not specific, but it's only indicative of neuronal injury. It's not diagnostic of Alzheimer's disease, but it does indicate that this is now progressing to dementia. And I don't know if you can see this, but in this study, it's terrible to show a graph like this, I apologize, but I want you to see the numbers for controls, stable MCI, meaning not Alzheimer's disease yet, other types of dementia, and then MCI from Alzheimer's disease and Alzheimer's disease. And you look down at biochemical on the bottom, CSF A-beta 42, and there's a drop-off, controls 670, and then MCI AD 386, much lower, and then Alzheimer's group 382. So it drops with MCI, and then it stays low through Alzheimer's disease. And then you look at phosphorylated tau, control 61, MCI, it's high now, 98.6, and it goes up a little bit with Alzheimer's disease. That's damage being done. This is what you get back when you do a CSF assay. You send it off to Athena Labs, and you get back, well, actually, you get back numbers on a graph and where that correlates to controls. And if you look at the upper left-hand corner, blue is CDR0, meaning no dementia, and green means MCI, 0.5. And you can see that the green people tend to be down here. So these are people with low, A beta is low. And then over here on PET imaging, amyloid imaging, they tend to be high. So their imaging is positive, their CSF A beta is positive, and they're in this quadrant. Well, you can also see some normal people in that quadrant too. Those people likely will develop dementia. They probably have high cognitive reserve. And then these data show CSF beta amyloid 42, generally low in the early onset dementia cases, if they're younger, a little higher in the older cases, and then higher still generally in the controls. Again, older onset, kind of a different disease. And if you look at AD8, so how they do on the Alzheimer's disease 8-question family interview, that is, they're functionally impaired by the family's observations, and their PET scan is positive for amyloid, well, then they do poorly, very poorly on a memory test. And then if their AD8 is positive and they have low A beta in their CSF, they also do poorly. So these biomarkers correlate well with memory, they correlate well with the AD8. Although you can have a positive AD8 but negative CSF, you don't do quite as well. You can have a positive family history for function, or family report of dysfunction, but your imaging is negative. You might have a different type of dementia. That's what that tells me. So these tests are helpful but not diagnostic. They have sensitivities in the 70 to 90% range. They're not very specific. If all three markers, A beta peptide, tau, total tau, phosphorylated tau, are normal, Alzheimer's disease is very unlikely, regardless of your age or your ApoE genotype. If all three are positive, above the 10% over the cutoff score, AD is very likely. With ambiguous results of PET scan, either with glucose metabolic scan or with amyloid imaging, may help clarify. But I want you to understand some of the background here. But until we have a disease-modifying therapies available clinically, is it worth doing spinal taps or getting people PET scans? We sometimes do it, especially for frontotemporal dementia, if that's in the differential and the family really wants to know. Do we do it in Alzheimer's patients only if a person's like in their 50s and 60s and really wants to know? But generally, these tests are not clinical tests yet. Once we have strong interventions, you'll be hearing more about these. So when we can identify this disease in the pre-dementia phase, or when there's a reason to do it because we have a primary prevention, that's when we'll be doing these tests more routinely. Okay, back to that issue with my aunt. Now, if you look at neuropathology of old people, 65 to 75, young old, 75 to 85, middle old, 85 and older, old, the pathology for these people, the bars all the way to the right, is different. They have Alzheimer's pathology, but not in the density and concentration and locations that the younger onset cases have. 85 plus, they have Alzheimer's pathology, but it's very hard to diagnose a specific disease. They have cerebral vascular change, they have Lewy body pathology, They have all the disuse atrophy that comes with being that old. So very difficult to be specific with an Alzheimer's diagnosis in that age group. All right, let's end by looking at some of these other dementias. There's vascular dementia, first described in the 1890s by Binswanger and Alzheimer, and long thought, of course, to be the primary form of old age dementia. There's onset and progression of symptoms related to stroke, single or multiple. They have severe white matter disease changes, and they primarily have executive function and gait changes. So it doesn't usually start with memory problem or amnestic MCI. These people generally have amnestic MCI and a different type of progression, sometimes described as stepwise, but if they have primarily small vessel disease, they may kind of dwindle like Alzheimer's patients do. But then again, they can also have comorbid Alzheimer's disease. So the National Institute of Neurologic Disorders and Stroke and this French organization called ARIN defines this as dementia with a decline in memory in 2 or more cognitive domains, excluding the usual things to exclude, cerebral vascular disease defined by evidence of cerebral vascular disease, and onset within 3 months of a known CVA or abrupt change in cognition, fluctuations, or stepwise deterioration. Now, often this gets diagnosed on the basis of white matter changes in the brain or some lacunar infarcts. I think you need a higher threshold. Should try to meet a higher threshold. The DSM5 criteria are very simple, or very similar in terms of defining this condition to be temporally related to cerebral vascular events. And scanning, evidence on scanning of sufficient injury to warrant dementia. What does that mean? We don't know. It's a judgment call. If they have lacunar infarcts and extensive white matter changes, you might consider this. And they have a lot of executive dysfunction and gait changes, poor balance. They look a little Parkinsonian, a little dyspraxia. They may indeed have at least comorbid vascular disease, which is a good thing actually, because you can use primary and secondary prevention for that, and they'll stay more stable. The Hushinsky ischemic score defines it a little bit. Abrupt onset, they get 2 points. Stepwise deterioration, 1 point. A fluctuating course, 2 points. Fluctuating course and nocturnal confusion, what does that mean? It means that these people get delirious. They get delirious off and on through the course of a day, like Lewy body patients get delirious. Someday we're going to distinguish acute delirium from chronic delirium. I'm using the term delirium a little differently than you've heard it already today. But people with certain types of dementia get delirious every day. It's called sundowning. Or they get delirious off and on through the course of the day. That's called fluctuating course. They get restless, agitated, hallucinate, very confused, disorganized. But it comes and it goes. Same pathology as delirium, but it comes and it goes. And that's a criterion for that one of the sort of features of vascular dementia. All right, so here's a person who does poorly with executive function. Their visual spatial is pretty good. That's pretty good. By the way, this is the second version, or maybe the third version of the Mocha. The Mocha website is great. It gives you 3 different versions of the standard scale. It also has a blind version, which eliminates these things. So you can give it to people with low vision. Great support. It's available in dozens of languages. Anyway, you can download these different versions of the Mocha. But this person got 25 out of 30. And then on a CDR, look at this. Look at this. Their memory and orientation are good, and you can see that on their Mocha. Let me see, 4 out of 5 memory and 6 out of 6 on orientation. And in day-to-day practice, yeah, their memory and orientation are pretty good, but they have some functional difficulties. This is vascular MCI. This is non-amnestic, multi-domain MCI. If you can reduce their stroke risk, they may stay like this for years. This is good. Frontotemporal dementia is the worst condition we're going to talk about today. This is the most tragic thing. Several different diseases come under this heading with midlife onset, mostly between age 40 and 70. There are different pathologies, there are different genotypes. We were taught that this was Pick's disease. It's a lot more than that. There is the frontotemporal dementia behavioral variant, which is kind of Pick's disease. This is where people develop personality and behavioral symptoms, disinhibition, hypomanic behaviors, substance abuse, very indiscreet behaviors. They get psychiatric diagnoses, often bipolar disorder, often addiction, gambling disorders before the dementia starts. And then it's finally recognized, often misdiagnosed as Alzheimer's disease when they start developing the dementia. There's primary progressive aphasia, and there's different presentations of this, all involving either grammar or vocabulary or fluency. There's frontotemporal dementia with motor neuron disease, like ALS. And then there's other things that sort of hang on to this group. We used to sort of put them in the subcortical Parkinsonian cluster. Now they're sort of hanging out with this cluster, the progressive supranuclear palsy diagnosis and corticobasal ganglia degeneration. So these people have dramatic frontal dementia, but also have dyspraxia, motor and motor symptoms, and severe apathy. This is a devastating disease. These people have kids at home. These people are working. Sometimes they just got into their second marriage. It's just awful. And the spouses go to Alzheimer's groups, and their issues are so different. We have a woman in our spousal support group, FTD support group. She's got 3-year-old twins at home. How many spouses in Alzheimer's support groups have 3-year-old twins to deal with? We have a mother in our family support, frontal temporal support group. It's a very different disease. Tough. People come from all over Maine to this support group because there's very few of them. It's a different disease. Lewy body dementia, the criteria are fairly sensitive and specific, but it so frequently coexists with Alzheimer's disease, it can be difficult to find a case that's really pure. They have 2 of 3 core features. They have fluctuating attention and concentration, they have recurrent visual hallucinations, and they have Parkinsonism, typically without tremor. There are suggestive features, REM behavior disorder, where they have dream enactment behavior. They kick, they thrash, they punch. Years ago, I remember a letter to Ann Landers where a woman was saying that her husband, during his sleep, tries to choke her and punch her. And Ann Landers says that he must have deep-seated hostility and he needs to see a therapist. And it was just a classic description of REM behavior disorder. We have spouses who are bruised and lamps get knocked over. And this syndrome has been shown in cat. If you watch your dog or your cat sleep and dream, you'll see that they try to run or something. They're having these little myoclonic impulses. Well, those impulses can actually generate coordinated activity in these patients. And it can happen years before they develop the dementia. It happens in Parkinson's disease dementia too. Supportive symptoms include falls, syncope, autonomic dysfunction, and delusions, commonly mixed with Alzheimer's disease. You diagnose Parkinson's disease dementia if they developed the motor symptoms way first. And you diagnose a Lewy body pathology if they develop the sleep disorder, the cognitive problems, before the motor symptoms. Also, Parkinson's disease responds much better to Sinemet than Lewy body disease does in terms of the Parkinsonism. Both these conditions generally respond really well to cholinesterase inhibitors. Lewy body patients will generally do very well on Aricept and Exelon and so forth. Both these conditions affect processing speed, attention, executive function, and visual spatial problems more than memory. They really look different than Alzheimer's disease. They know what's going on. Their language is intact. They have a lot of apathy, depression, and anxiety, and they're very sleepy, in addition to having the REM behavior disorder. Schizophrenia used to be, was in the 19th century called dementia praecox because they have profound executive function. So these people with schizophrenia can actually be demented, functionally demented, even though they have good memory, but their executive dysfunction is severe enough that, it can be essentially, they're functionally demented. It's very impairing. Anxiety disorders typically would give MCI level impairment that tends to fluctuate. Depression, on the other hand, is a much more complicated thing. It affects memory, attention, executive function, and it's variable. It fluctuates too. But depression is often unmasked by a latent neurodegenerative process. It can be an early symptom of that process. And it may even, it appears to accelerate dementia from Alzheimer's disease by eroding cognitive reserve. So it's a complex relationship with dementia, but, and I would caution you not to diagnose Alzheimer's disease or progressive dementia in someone who's very depressed until you get to follow them over time. Finally, TBI and alcohol. Traumatic brain injury causes persistent impairment, which may occur with mild impacts, particularly multiple mild concussions. And cognition may improve with time, but progressive neurodegeneration also, as you know, can occur both from single and multiple impacts. And alcohol can cause both a generalized dementia that usually improves with sobriety over several months, but it also causes a severe amnestic syndrome, which tends to be persistent, called Korsakoff's, called Wernicke's disease. All right, let's end by summarizing some of those conditions. So, Alzheimer's disease, generally diagnosed in someone who's older, but not always, at least in young, old, or middle old age. It's characterized by poor memory initially, less severe executive problems initially, normal to mild attention problems. Their attention is usually pretty good. Their motor findings are a little subtle. Typically with Alzheimer's disease, you'd have a normal neurologic exam, and that's supportive of the diagnosis. However, there are some tests you can do that you'll see in people with Alzheimer's disease. There is this motor slowing. There's also dyspraxia. If you have them do a Luria maneuver, a 3-step sequence, they're very clumsy in learning it and executing it, especially with their non-dominant hand. We're all a little dyspraxic with our non-dominant hand, but if you have them do a Luria maneuver, they'll have trouble learning and doing it. If you have them do a timed up and go test and then give them a cognitive distraction, you'll see they'll stop in their tracks. We have them say months of the year backwards, December, November, October, so forth. Very, very difficult for them. It at least doubles their time. So they can't multitask on motor tests. They have problem with motor sequencing, learning motor sequencing. There are these subtle abnormalities that are starting to develop, but their gait and balance should be good, and that's good evidence actually for Alzheimer's disease without another comorbid condition. Vascular disease patients, they're older, they have slow retrieval, more severe executive problems early on. They have focal neurologic findings and extrapyramidal syndromes. Lewy body patients, dementia with Lewy body patients, they're older, they have slow retrieval, more severe executive problems, very, very poor attention. As I say, it's like they're chronically delirious. They have akinesia, that type of Parkinsonism, and they have REM behavior disorder, and they have visual hallucinations. FTD patients tend to be younger. They have concrete, disfluent speech. They have attention problems like they have ADD, and they have a lot of psychiatric symptoms, personality changes, apathy, disinhibition, sometimes delusions. We didn't talk about normal pressure hydrocephalus except for here. They tend to be older. They have cognitive slowing. They have gait dyspraxia and apathy. And they have urinary incontinence and gait problems that precede the dementia usually. And major depression, they tend to be older when they get demented from depression, slow retrieval, very slow processing, and they have affective symptoms. They're sad and they're anxious. Okay, well, we did a lot. Thanks for sitting through it, and I hope it was helpful. We covered some material that I think it's good to at least have some awareness of biomarkers and how that will factor in to the diagnosis of dementia and Alzheimer's disease. I hope you have a little more confidence in distinguishing or at least describing and explaining mild cognitive impairment to your patients. Okay, thank you. Oh yes, I'm sorry. In an endemic area such as ours, have we seen cases that we were convinced were due to Lyme disease? We've had patients who were convinced that they've had Lyme disease, and we were not so convinced. One of whom even had a positive PET scan and CSF findings for Alzheimer's disease, still thinking, he still thought it was, and his wife still thought it was Lyme disease. But I think we have to be alert to it because it happens. I suspect neurologists would see it more than we do because they often have peripheral neuropathy and other neurologic symptoms. You're right, it should be on that list. It's not on the list of general practice guidelines, but it should be on our list. If you have a person who, especially if they have peripheral neurologic findings and exposure, as many people around here do. How many people draw a Lyme test routinely on a cognitive assessment? Quite a few. Yeah, it's probably a good idea. Yes?
I've seen some data that seems to suggest that we're very much underdiagnosing NPH. And I know it's a little difficult to diagnose. Everyone has atrophy. Often you get the scan and they say, well, you know, maybe the ventricles are a little more atrophic than, you know. Could you comment on that?
Yeah, I think radiologists, thank you. The question is, can I comment on whether or not we might be missing NPH, that normal pressure hydrocephalus might be more common than we generally refer patients for. I find that radiologists are very sensitive to that asymmetry in ventriculomegaly and cortical atrophy. So if the sulcal enlargement is slightly less proportionately than ventricular enlargement, or there's a bit ballooning appearance in the ventricles, the radiologist will often usually mention it as a clinical rule out. Sometimes I see what they're referring to and sometimes I don't. I rely on the history of gait changes if it really looks like gait dyspraxia, and the incontinence, it's hard to quantify. And if the dementia or the cognitive impairment is early, then I might be more inclined to refer a person for a therapeutic tap to see if they can walk. Often a person has gait challenges, and even if they got a spinal tap, you wouldn't really be able to assess their gait to see how well they improved, and you really can't go by improvement in cognition. Some people might improve with a therapeutic tap, but it's really the gait that's more predictive of a response to a shunt. I can't say whether we're underdiagnosing or not because I don't know how often we miss it. It's certainly something you've got to be thinking about, especially when you get the report from the radiologist. I mean, so many of our patients have gait problems, incontinence, and cognitive difficulties. So the triad of symptoms isn't really helpful in distinguishing, but the history is, did the gait, because in NPH the gait problems start early and the incontinence problems may start early, before the cognitive problems do. Whereas usually in dementia it's typically the other way around. Other types of dementia is usually the other way around. It's a good comment. We all have to be aware of that condition, but I don't know of any data about how often we're missing it. Does anybody know that or have a feel for that? No. We just have to be alert for it. It's a good thing to bring up. The question is for me to comment on diagnosing dementia in someone who's already cognitively impaired or has a developmental delay or a mental illness. Let's get to the developmental disability first. As many of you know, people with Down syndrome have rapid amyloidosis and a high risk of developing Alzheimer's disease in midlife. When do you diagnose dementia in somebody in whom you cannot do a cognitive test because you don't know what their baseline is on that cognitive test? So you rely on functional measures, and a national task force 2 years ago published an evaluation scheme for this situation of the kind of functional assessment that you would do to detect or document the cognitive decline in a person. So I make that diagnosis on the basis of functional assessment because you really can't go by cognition. I do ask memory questions because that presumably would get a lot worse if a person with Down syndrome is developing Alzheimer's disease. Their memory, which may have been impaired to begin with, but clearly is going to be worse. They're also going to have more hallucinations and delusions and agitation and the full spectrum of neuropsychiatric symptoms. But they're also going to stop doing things for themselves that they previously had done. Now, people with non-Down's syndrome developmental disabilities are also likely to be at higher risk for dementia, although not as high as people with Down syndrome. Excuse me. Simply because they have less cognitive reserve and often other risk factors for developing dementia. So it's the same thing applies to them. You would determine how their function has changed over time. And if it looks like it's been gradually getting worse and not due to something else, then it's very likely that they're developing comorbid Alzheimer's disease or some other dementia like vascular dementia. But you have to do it on the basis of functional assessment and not cognitive testing. The question is, does telling a person that they have Alzheimer's disease make them worse? And memory function is sensitive to expectations. So in fact, if you make a person feel old, their memory, if you say something that makes them feel old, their memory won't be as good on a test. And certainly, if you make them think they have dementia, they're going to have more performance anxiety, and they may not do as well on a test. But generally, you won't send someone into a catastrophic reaction. I think that's the fear we all have. But generally, people want to know. Now, we all have had families tell us, don't tell them, don't tell her. You know, you have to play that by ear. I think people have a right to know what to expect. They have a right to know their diagnosis. On the other hand, there are people who may be very sensitive to that information, and you have to soft shoe it a little bit and use words like memory impairment, memory problem. There are people I don't use the diagnosis with for that reason. I may have discussed it with the family if I thought that they could handle it and be productive, could use that information. I think at the very least, somebody in the sphere has to know that this is a progressive problem, so that, you know, resources and steps of care have to be initiated. But you don't have to be blunt with the diagnosis if you suspect or the family pleads that you don't use that term Alzheimer's disease.